Okay, so I would like to focus on what we have learned over the past 40 years from the International LKTS Registry. And I would like to make this interactive because it's the most scientific evidence that we have advanced because of you. And if you have any questions while I'm talking, because I'm intervening with patient care, science, clinical implications. So you're welcome even to stop me, raise your hands, and if you have any questions, I will be happy even to stop and answer you. So the International LKTS Registry, like Dr. Zariba mentioned, is an international collaboration, US, Europe, Israel, Japan, over 8,000 patients. We have right now genetic, we have all the ECG, we have the clinical, and we have yearly follow-up from birth now until the age of 90, even 100, because everybody with long QT right now, if they are recognized, can live a normal life with a proper intervention. And what we have learned initially when the registry came out 30 years ago, we have learned that there are clinical risk factors and electrocardiographic risk factors because we didn't have genetics at the time. So there was age, sex, ECG. We looked at the electrocardiogram. We were able to identify patients at a high or low risk, clinical history, whether the patient experienced syncope or not, and a family history. And as we became more advanced, and this came in more recent years, we looked at the genetics. And then within the genetics, we identified that for certain genes, there are separate triggers. For LKT1, for example, patients have a higher likelihood of experience events during exercise, LKT2 during emotion, LKT3 during sleep. And this allows us for better intervention and risk stratification in those patients. And as we became even more advanced, we look specifically within each genotype. For example, in LKT1, there are certain areas in the gene and the channel that have a higher risk compared to other regions. So they're more likely to receive better therapies affecting not only the genotype, but also the mutation location within each genotype. And I'm going to show you this even in a more specific genotype talk later today. So this is, again, this is more basic, but I would like to translate it into more clinical implication for you. For example, let me just, where is this? Okay. So, no, oh, this one? Thanks. This one is not for. Okay. So let's look at the main genotypes of LKT1, 2, and 3. And we're seeing that in LKT1 and LKT2, there's a problem with potassium getting out of the channel. So if the potassium doesn't leak because of the mutation out of the channel, there's an increase in what we call the QT interval between the time when the heart contracts and the heart relaxes. And because this electrolyte doesn't get out of the cell, all this interval is prolonged and it comes into the next beat. And once beat gets into the next beat, there's a higher risk of arrhythmia because they're all mixed together. And that's the reason LKTS patients with long QT have a high risk for arrhythmias. So this is one mechanism, potassium. The other one is sodium. In here, there's also a problem with sodium coming into the channel, and if this sodium leak into the channel is extended, also this QTC interval is also prolonged, and there's also a higher risk of heartbeats coming one to the other, mixing with each other, and having a higher risk for arrhythmias. So any questions for now? That's good.
So sodium and potassium are both factors in any long QT?
No, that's the reason I showed it to you. So in LKT1, there's potassium, a certain potassium channel. LKT2, there's another potassium channel. In LKT3, there's the sodium channel. So each one is affected differently, and that's the reason I wanted to say that we have advanced for just general therapy to more genotype and even mutation-specific therapy. So that's the reason genetic testing is so important in long QT syndrome, but also in other inherited arrhythmic syndromes. Yes, Dr. Lowenstein.
Can you explain for us the left side of the slide? The on the left there?
Yeah. So here you see what happens when the heart, the electrical activity in the heart begins. So like Dr. Zoriba said, there's an upper part of the heart which can cause atrial fibrillation, there's a lower part. So this is the activation of the upper part. Once the electric activity happens in the upper part of the heart, it contracts, and then blood flows into the left ventricle and right ventricle. And once blood flows there, there's activity in the lower part of the heart. This is the electrical activity, and the heart contracts, and then blood comes into our body. So if this area does not contract, there's no blood flow to the brain, the liver, the gut, the muscles in the entire body. So this is the activity that gets the heart, the blood to flow into the left, into the ventricles. And once the ventricle contract, there is this period of the QT interval in which the heart continues to contract until it relaxes. And this is the time of the relaxation until the next heartbeat. So if this period is becoming prolonged, like in long QT syndrome, you see there's a higher likelihood of this period going into the next beat. And then when they all get mixed together, there's a high chance of arrhythmias. And this is the problem with these sodium and potassium leaks. If they are extended, this causes this type of prolongation and a higher propensity for arrhythmias. I'm sorry, what inverted T wave. In long QT, because of all this extended period, like Dr. Zoriba said, there's changes in morphology. Usually inverted T waves occur in other inhalers. Yes. So we can think of in the future, and I'm going to talk about it later, maybe of some therapies, even oral contraceptive, in which there's a higher concentration of progesterone as opposed to estrogen, and this may reduce the risk. And the next risk factor we identified is something very simple. If you look at the QTC duration, we're seeing that patients, especially women, but we're going to talk about it a little later, but those who have QTC below 500, they have a significantly low risk as compared with those who have a QTC above 500.
So less than 500, they have low risk, higher than 500, they have higher risk.
Yeah, we now know, I'm sorry, yes, go ahead.
But men have greater chance above 500.
It's very much age dependent.
This is childhood. This is childhood, and again, I'm talking about this in general because I want to show you how we have made some progress. So we initially started out with QTC, sex, and age, and now we know that even those who have below 500, if they have a certain genotype and there's a certain age that's affected by progesterone, I'm going to show it to you later, they may increase the risk. So this is something like more of a history to show that in general, a higher QTC is associated with more propensity for risk of sudden death. Yes? Yeah, let's go back to this ECG that I showed. So it's actually from here, the beginning of the QRS to the end of the T. And this is also very challenging, you know, because we have made a survey of about 500 cardiologists all around the world, how to interpret the ECG. And we have shown that general practitioners don't have a lot of experience because this time interval is very tricky. Sometimes the T wave doesn't really come out to the baseline. Sometimes it goes below, sometimes it continues. So some general practitioners don't know how to interpret this. Even specialized electrophysiology don't have a lot of experience with this type. So again, it's very tricky. So we talked about QTC. And let's talk about QT. Again, we're talking about childhood here, but we're talking about patients who have had syncope in the past, and now we're looking at the risk of sudden death. So taking very careful history of syncope, and I know that some of you talked to me yesterday and told me that some of you or your family members were identified as having syncope or even seizures, and you started therapy for neurological disorder rather than long QT. So taking very careful history from the patients and looking at the ECG, we'll be able to identify those of a high risk and to treat them more appropriately, specifically for the disease. And again, looking at the number of syncopes. So patients who have a lot of syncope, they have a higher risk. But interestingly, we also looked at family history. Let's say there's a family with a lot of people affected, a lot of family members, some family members affected by long QT. So if there's in this specific family, there's a risk of sudden death, it doesn't mean that the sibling still has a higher risk. On the other way around, if there's no history, it doesn't mean that the sibling or the family member does not have a higher risk. So it more depends on the personal history of the syncope, of the QTC duration of the specific patient, the mutation. So it's not the family history in this specific disease does not contribute as much as other risk factors. Yes, I see that there's a question.
Does that mean that if you have a family member that has been diagnosed as not having long QT syndrome, that once they do not have it, they will never have it, or can they acquire it?
So if you are asking whether there's no long QT syndrome genetically diagnosed, if there's sudden death for other reason?
No, if they can acquire long QT syndrome.
No, it has to be inherited.
So it is from birth.
It is from birth. So for example, if a family member has been tested for long QT syndrome and yet he or she has been identified as positive, and you test the other family member for the same gene, you don't have to do a lot of extensive testing, and if the answer is negative, this patient will not develop the disease as the other.
Pass it on. Can they pass it on?
No.
Okay.
If it's negative, they can, but they can pass on. You know that we have a huge genome. We can pass other things. I'm pretty sure that I have something as well. Yes?
I have a question. I have a younger sister that was, when I was diagnosed 42 years ago, my whole family was tested. And she was diagnosed with that fact that it could be achieved. And she came out, they came up with a borderline test for her. She hasn't had major symptoms just like her mother had it.
Yeah.
But now all of a sudden they're saying she doesn't. I guess I'm kind of following her with this stuff because I believe she has it, but I don't know if some of it out there.
So if, for example, you know that about 1/4 of patients who have long QT syndrome have a normal ECG. So and we identified it because of you, because of the family members. So if the family member has a proband, like Dr. Zoriba said, there's a proband who has experienced symptom, and then we go to the family member and test them, 1/4 will have a normal QTC. And then if we test for the same gene, and I'm going to talk about it a little later today, if the gene is high risk, so this patient, despite of the fact of having a normal QTC, this patient may still experience symptoms because the gene or the mutation is still at a high risk. So now we are combining those clinical markers with the mutation-specific markers. And this is a more of a pyramid that we created in the past. So in the past, before we had the genetic testing, just based on the patient, on the QTC, and if the patient had a QTC below 500, no history, we considered the patient to be at a low risk. The risk was 0.5 over 5 years. If the patient had a history of syncope or QTC above 500, either one of those, the history was 3% over 5 years, the risk of sudden death. And very high-risk patients who already experienced an event should get an ICD because their risk of over 5 years is 14%. But this is regardless of genetic testing. This is more of a general risk stratification in LQTS patients. questions about regarding this pyramid. Yes?
How do you risk yourself? I mean, how do you place yourself in that?
So Wojciech just showed before, we have a calculator that we're going to post online in 1 or 2 months, because we have that now more extensive information, not only on those risk factors, the age, the sex, the QTC, the beta blockers. We can now include in this calculator also the genotype, the mutation, and then we can test ourselves. And now we're doing this more specifically for women and men, so we can have those calculated for all the families online in 1 or 2 months. Yes?
I got another question. You see it. I'm very basic, sorry about that. But, I never make it. You see what's that?
Okay, that's good, because that's the reason I wanted the discussion to be interactive, because let me just go back to the ECG here. Okay, so, and I have to use this one. So QTC, again, as I said, is the beginning of the QRS here to the end of the T. This is the interval, which is called QT. But QTC is QT corrected, because when we go for faster heart rate, the QTC becomes short, but in people that have the gene, the QTC doesn't become short enough adjusted for heart rate. So we still have to correct the QTC for the heart rate. So if there's no QTC, if there's no long QT syndrome, once we go for faster heart rate, the QTC becomes appropriately short. It goes down from 500 to 400. But if we go for exercise in an LQTS patient, it may go down for 500 to 490, which is not sufficient, because then it can go to the next beat and create an arrhythmia during exercise. So QT is the interval between this point and that point, and QTC is the adjustment, the corrected adjustment for heart rate. And now we're going into the genotype. So we started to identify that for each genotype, the mutation that I mentioned, the fact that there is potassium problems in one channel, or potassium problem in the other channel, or sodium, is also affecting the clinical course of each patient. So LKT1 patients are more likely to experience sudden cardiac death during exercise, because you know that there's a lot of adrenaline during exercise, and the mutation in LKT1 is mostly affected by the adrenaline of exercise. In LKT2, the potassium channel here is more likely to be affected by emotion, because there are different receptors for adrenaline during emotion. In LKT3 is more likely to be affected by events during sleep because of the sodium channel. So again, we have to consider the mutation and the genotype when we talk about how to treat, to better treat and identify patients. Yes?
So the sleep portion, I'm just looking at the sleep portion in general, that is referring to obviously sudden cardiac
Death, yes.
In your sleep for potassium reasons in long QT2.
So, yeah. So in LQT2 there is some sleep, but here again I'm not going to go to it very in depth. But in LQT2 it could be someone who's been awakened suddenly during sleep, and there's a lot of adrenaline. In LQT3, interestingly, because of the sodium, it doesn't have to be startling during sleep. It could be because during sleep the heart rate becomes so slow that the QTC increases, and then it can be this vicious circle of beats can go into one another. So it's a slightly different mechanism.
So from the long QT2, the sudden awakening during it's not you go to sleep and you die.
Yes.
You're awakened by noise or something.
Something like that, and you're being startled, and there's a lot of adrenaline coming in, and this affects this vicious cycle of beats. In LQT3, the mechanism could be slightly different. The patient can still continue to sleep, but the heart rate becomes slow, because we are so relaxed during sleep, and this creates this type of vicious cycle, and this is the sodium effect.
So without arousal, that just means you're sleeping.
Yeah. And then Wojciech in the New England Journal, this is not actually okay, but in any case, but it's your concept. In any case, we identified LQT3, if we look at general events, syncope, which is most of the events that we got from you, which are not life-threatening, LQT2 have a high risk. But if you look at lethal events, because of this, sleep and bradyarrhythmia, the sodium, and possibly because those patients who have LQT3 are less responsive to beta blocker therapy, there's a high risk of lethal events, sudden cardiac death, rather than syncope in LQT3. So this is also the importance of genetic testing in this population. But now, and I'm going to talk about it a little later, we went even beyond the gene. We looked within each gene. There are certain areas that are more likely to be affected by sympathetic or adrenaline. And we show, for example, that in LQT1 there are certain areas, I'm going to talk about it later, but I just want to demonstrate the concept. You see that from birth until the age of 40, the risk of events is 50, as compared with only 20 if some areas in the gene, the mutation is located there as opposed to others. And we also can carry now, we have an ECG core lab in our research center, and in using a Holter, we can do a more personalized risk stratification for each patient by creating a QTC clock, looking during the day what happens to the QTC interval, and then assessing the risk of an individual patient. This is just a concept, and I'm going to expand on this. And right now, you ask me about the calculator. We're looking, for example, at women, and we're seeing that if we incorporate the QTC of a woman, the treatment with beta blockers, the mutation, the genotype, everything together, we can correlate the risk of events from adolescence to the age of 60, going down from 70% to only 10%. So we can have a calculator for each patient. And we'll end with an example, I think. So in LKTS, again, the main question, and I was asked about it before, some people here, beta blocker will be enough. And so some patients, they may need an ICD. So in general, when an ICD is indicated, can we be sure that beta blockers are sufficient? So what we identified that, for example, if a patient's experienced already aborted cardiac arrest, a sudden death, a high risk of arrhythmia, this patient for certain should get an ICD. A patient without a high-risk mutation can be generally safely treated with beta blockers unless there's syncope on beta blockers. But a patient who has a high-risk genetic mutation, these patients should be carefully considered for beta blockers rather than an ICD, and I'm still going to talk about it a little later. And I will end with an example for one of the patients from our registry, a 12-year-old male. The patient has been known to have LQTS. The patient's experienced recurrent syncope. The patient was treated with beta blockers for several years. But then, again, this is something that I mentioned. We learned about it. If the patient experiences recurrent syncope despite beta blockers, this patient should get an ICD. That's what happened. The patient got an ICD. And then with the ICD, an episode during the first day of school in 1998. And we're seeing this episode. You see what happens. The QTC here, this is the QTC, the beginning of the QRS to the end of the T. It's very prolonged. And this goes, and this is the reason these beats get into the next heartbeat and causes this malignant arrhythmia that sometimes when the patients experience syncope, it means that the arrhythmia stops spontaneously, but sometimes it doesn't stop and goes out for several minutes, and this is what we call sudden cardiac death. And the ICD effectively delivers therapy here, and then the patient goes back to sinus rhythm, and the life is being saved. And this is, again, we're seeing what happens to a patient who has an ICD, almost no events, versus those who are very high risk or don't get an ICD in the registry. So in summary, throughout the years, we have learned, based on the largest inherited arrhythmia registry available, how to expand the recertification therapy from simple clinical risk factors syncope, QTC, family history, to more genotype and personal risk stratification and treatment. And thank you.